Hi all, welcome to Getting Surgical Documentation Right, a fireside chat. My name is Jordan Leibnitz and I'm part of the marketing team here at IML. We have five panelists speaking today. For starters, our moderator is Alex Dawson, product manager at IML, Janice Kelly, president at AORN's Integrity, Luann Montgomery, nurse informaticist at IML, Dr. Julie Glasgow, lead clinical terminologist at IML, and last but certainly not least, Whitney Mannion, clinical terminologist at IML. With all of this being said, I will pass it over to our moderator, Alex Dawson.
Thanks, Jordan. You know, on a daily basis, the surgical department faces one of healthcare's most difficult challenges: how to deliver high quality, efficient, and cost-effective care. So as we shift to a more value-based care payment model, there has been an increased pressure to deliver timely, accurate, and compliant clinical documentation within the healthcare organization. Evolving clinical documentation guidelines make it more challenging to capture and code the complete patient story than ever before. So in today's discussion, we're going to talk about the importance of surgical documentation and its impact on compliance, patient quality of care, and surgical reimbursement. So given the new mandates set forward by CMS, the Joint Commission, the World Health Organization regarding clinical documentation guidelines, clear and concise medical record documentation is critical to providing patients with quality care, and it is required for providers to receive accurate and timely payments for surgical services. So I want to talk to each of you about what is required to be compliant with documenting properly. So in honor of Perioperative Nursing Week, I wanted to start with Janice. Janice, AORN's guidelines for patient information management have 4 recommendations focused on documentation of patient care information within the perioperative setting. Can you talk about a little bit about why these recommendations are so important?
Yeah, Alex, thanks for the question. And for those who may not know, the AORN guidelines for perioperative practice are nationally recognized as the standard of care for patients undergoing surgery. And because of that, the guidelines are used by CMS, the Joint Commission, and others to judge the care your organization provides. Within the patient information management guideline are recommendations to assist perioperative nurses in documenting patient care information. It states documentation should reflect the nursing process. And what that means is documentation should include the assessment findings, the care you provided, and the patient's response to that care. And this provides a consistent way to promote the continuity of care. Documentation should also align with the standards of practice, of perioperative practice specifically, and regulatory requirements so you can evaluate compliance. All of these recommendations are important to support the complete legal record of care.
Thanks for that answer, Janice. So it's clear that nursing documentation is vital piece here. So, but what about from the clinician's perspective? And for that, I want to ask Dr. Julie Glasgow. So what are some pertinent facts needed by clinicians specifically for surgical documentation?
Yeah, absolutely. There's a wide range of details that have to be recorded by clinicians of every kind that take care of patients in the perioperative, intraoperative, postoperative period. For the surgeon, one of your main tasks is to make sure that the right operation is being done on the right person at the right body location. It's one of those right patient, right side, right procedure kind of requirements. So actually that means a lot more than just making sure that there hasn't been any kind of mix-up. That's a situation that always has to be guarded against. But there are all kinds of pertinent patient details that have to be captured. The diagnosis that has led to the operation, right? You have to have the right indication for the operation. For instance, like osteoarthritis of the knee, that would be a reasonable indication for a knee replacement. knee sprain, that would not be. You have to verify in the documentation that you have the correct side that you're planning to operate on. You don't want to replace the good knee. You have to think about any potential issues with this particular patient that could make the procedure more complicated, more risky. Is this a redo of a previous knee replacement? Does the patient have heart disease? Do they have any other underlying condition that might make them too unhealthy to withstand the operation? So all of these things require that you've seen the patient, you've examined them, you've taken a really good history, you've documented all of that. You've probably done a lot of labs and studies. That all has to be carefully documented and evaluated, and your line of reasoning documented. And that's before you can even schedule the operation.
Wow. Great, thanks, Judith. Those are some great examples. So what it's making me think of is just with all of those changes, that's going to impact the coding of the documentation, and specifically the CPT mapping requirements. So now, actually, Whitney, in terms of CPT requirements, what is required for surgical documentation?
Well, that's an interesting question, Alex. Like Julie was saying, before surgery, important pieces of information needed are the diagnosis, what surgery is going to be performed, prior authorization, and possibly validation of the diagnosis or proof of medical necessity. So that can be pathology reports, labs, and other preoperative testing can come into play here. During the actual procedure, as with any other area of nursing, if it wasn't documented, it wasn't done. Janice mentioned earlier that the medical record is a legal document, so all aspects of patient care performed become a part of that record. Before the surgeon leaves the operating room, the circulating nurse confirms what surgery was actually performed and the level of contamination, which becomes important for proper billing and ties into the operative report that the surgeon generates. So after the surgery, the surgeon needs to complete their operative report. This op report is one of the most important documents needed for accurate coding, since it contains all the details of what was performed. Typically, I believe it has to be completed within 24 hours of the operation. Some examples of buzzwords that coders look for in the op report are quantity, severity, site size and depth, approach, whether open, laparoscopic, or some other kind of scope was used. Was it robotic? Did another surgical team come in? What was the level of contamination? All things mentioned in the op report provide the coders with the information they need to drill down to the most appropriate codes for reimbursement.
Thanks, Whitney, for that. Some great detail. And I'm kind of picking up on a theme even as we're going through this of some of the legal implications associated with incomplete documentation. So now I actually want to turn to Luann and ask you about what are some legal risks associated with incomplete documentation?
Well, great question, but first, as Whitney said, if it wasn't documented, it wasn't done. I mean, that's one of the first things that we learned in nursing school. And one of my best nursing instructors told us that when you document, just think of it like telling the patient's story. So anyone that's reading that chart, whether it's in 5 years or heaven forbid projected on a courtroom wall, they should actually be able to tell the entire patient's story just by reading that chart. So considering this, we got to document everything, every intervention, every assessment, and then that handoff, both completely and accurately according to whatever documentation system used at your facility, and then keeping in mind the ANA standards for documentation. And then there's another layer. You got to remember what laws you're working with, whatever state you're in. So speaking of that, the state and federal mandates are now requiring electronic documentation. So we got to be vigilant with the workflows developed and allow for documentation tailored to each patient. So the risk might be that the documentation can sometimes become redundant, and the nurse might just kind of succumb to clicking boxes automatically without reviewing whatever's pre-populated in those fields. And that's one of the pitfalls of auto-populate features. So EMRs are great tools. They're very powerful, but we must remember to correct that documentation to make sure that it is correct before we click in and out of that. So that's a long-winded answer, but Alex, there is a lot of room for incomplete documentation, as you said, such as maybe a surgical site that was assessed but never documented. But there's also room, on the other hand, for incorrect documentation. So a site that was documented, but it could be easily documented in the wrong place, like on the wrong extremity, perhaps.
Thanks, Luann. So I think we established in the conversation so far that good documentation is important to protect patients. It promotes patient safety, quality of care, and complete and accurate record keeping can really help ensure that patients get the right care at the right time. So with all that being said, though, and Luann, I think you kind of mentioned this too, of just safety of the patient is the #1 essential metric. Need to have safety for our patients. So Luann, if you could just go back and talk a little bit about how important good documentation is to healthcare organizations and how it's used within those facilities.
So, as you said, that patient safety is always first, and we have to document that patient safety, or document everything that was done safely. And the quality is key for many reasons when it comes to this, but reporting is very, very important for facilities. And there are many tools that hospitals use to measure and report those safety processes and their outcomes, both internally and externally. And the medical record should contain all the documentation needed to comply with the regulatory requirements, accreditation measures, national practice standards, and all mandatory reporting criteria for those quality performance reimbursement. And Janice mentioned some of those earlier, including Joint Commission. So some others that come to mind, CMS's quality indicators, and then physicians' quality reporting system measures. So those are both examples of some value-based metrics that hospitals are being asked to provide. And both of those payment models are highly based on quality measures and documentation. And I don't know how familiar people are with this, but Leapfrog Hospital Survey on Safety and Quality is a public site based on hospitals' reported outcome measures. And then they have another initiative called Hospital Safety Grade that assigns letter grades to hospitals based on their record of patient safety. And the public can go to this and they can look at how hospitals are rated based on their errors, injuries, accidents, and infections. And then lastly, as Janice mentioned earlier, the AORN has created their evidence-based guidelines for perioperative nursing practice standards. So once again, it all relies on what's documented in that patient record.
Okay, so clearly documentation is a big deal for organizations and for patients, but what
Yeah.
about the patient? How is the patient experience impacted by documentation practices? So let's start with patient safety and turn back to Julie. So what are some patient safety risks associated with incomplete documentation?
Well, sure, yeah. Well, all those factors that I mentioned before, right patient, right side, right procedure, making sure they don't have comorbidities that increase their risk, those are all really, really important. But all throughout your patient care in the surgical setting, you're thinking about patient safety. As you prep the patient, as you position the patient, and as you actually carry out the operation, patient safety is at the foremost of your thoughts. It's actually pretty common to discover things in the operating room that aren't according to your plans. Things can come up, unexpected things. Those always have to be, noticed, seen, really importantly, documented. A lot of them are very, very impactful for patient safety. And I guess I can give you some examples. So imagine you're planning to do a bowel resection. So you're removing a diseased part of a patient's colon. Before your operation, you're pretty sure you're going to be able to connect the two cut ends of the colon back together again, right there in the operating room before you close up the incision. Well, imagine you discover that the tissue is actually, it's in worse shape than you anticipated. So you decide, well, we better give them a colostomy bag. So we're going to change our plan. We're going to give them a colostomy bag. Maybe we're planning on taking that down the road, weeks or months down the road. But it's so important to document all those unexpected things that come up in the operating room so that, the patient is going to know what to expect down the road, and the folks taking care of the patient right in the immediate post-operative period, they have the full picture in mind so that they can give everyone the right instructions, the right follow-up plans, all of the details that crop up during an operation are vitally important for patient safety. If any of them are missed, it can lead to safety risks. We can't have that.
No, can't. And you raised some really good points there, Julie. I really hadn't thought about the impact of something unexpected happening and what that might mean in terms of documentation and patient safety. That seems like it would happen quite a bit. So let's say the patient is in one stage of the perioperative phases of care and now needs to transfer to another. And actually, I'll go back to Janice. So Janice, how is perioperative documentation used in the transition of patient care?
Well, as Julie, Whitney, and Luann all mentioned, documentation should include patient care important to ongoing clinical decisions and to support the transitions of care. Information documented in each of the phases of perioperative care provides detail about the patient's current status, such as what Julie mentioned of change in the surgery, as well as treatment or procedures performed. I believe it was Luann who mentioned if critical information is missing, patient safety and costly mistakes can occur. So for example, the pre-op nurse identifies the patient as a high risk for a perioperative pressure injury, but that is not communicated to the intra-op nurse. So that intra-op nurse is not notified of that high risk, so she doesn't take appropriate precautions and doesn't implement the different things you need to implement when you're positioning the patient, like adding maybe a gel pad or whatever type of tools that you might have at your organization. And the patient develops a hospital-acquired pressure injury. That can be a costly mistake, and it can also lower the hospital ratings, as Luann mentioned. So Alex, as you can see, perioperative documentation is important in the transition of care to communicate information so clinicians can make appropriate decisions.
Clearly, that does seem to be the case there, Janice. But isn't it also true that safety risks, transitions, and communication all really impact the quality of care provided? So, Whitney, actually, could you talk about how having pertinent documentation affects the patient quality of care?
Sure. It's a complex question in some ways, but all care provided during surgery must be documented, as we've mentioned numerous times in this chat that we're having. So everything from the preoperative timeout, patient positioning, who was present in the room and their role, any specimens obtained, supplies and implants used, having correct sharps counts. Not only does this ensure that safe care was provided, it gives that overall picture of what happened during the procedure and allows for a complete record if there's ever any future discrepancy, product recall, or, hopefully there's not a projected on a courtroom wall, but it's possible. Some documentation can help drive continuity of care for the patient after the surgery. So some examples of that are locations of incisions and drains, the appearance of the surgical site before the dressing was applied. That can be important because a lot of times the surgeons want that dressing to stay on for, 3 or more days without getting removed. So let's see, any drugs administered intraoperatively, accurately labeled specimens obtained during the procedure can also direct future treatments that the patient receives. So if all of these things aren't documented and communicated properly, patient safety and quality of care can be compromised as a result.
Thank you, Whitney. So So far, we have covered documentation from a compliance perspective and in terms of how it impacts healthcare orgs and patients. But I think I can speak for the audience a little here when I say that as the COVID-19 pandemic continues to evolve, it is clear that the virus has already and will continue to have a significant financial impact on hospitals. With this being said, proper clinical documentation can help facilitate effective revenue cycle processes as well and expedite payments. So there is a financial component here as well. And we talked about CPT codes a little bit earlier, but now I'm curious how the documentation is used. So Julie, actually, let's go back to Julie. So how is documentation used to support claims billed?
Absolutely, Alex. So yeah, COVID-19, it has such an impact on hospitals and healthcare systems. It doesn't look like it's going to be letting up anytime soon. And all of that is such an unfortunate situation. The operating room, it's usually a pretty significant revenue generator for any health system. There have been so many elective surgeries that have had to be canceled, and it looks like that is going to be, ongoing. And that just makes it so much more important that when folks resume their normal operating room activities, they have to make sure their processes and their documentation are as efficient and effective as they can possibly be. So yeah, the op note, that all-important little document, you can kind of see it as something that CPT codes kind of grow out of, right? Really, really central to billing. It needs to contain detailed descriptions of everything that was done during the procedure. Sometimes it's not the same procedure as you pre-authorized. That's actually a pretty routine occurrence, but you just have to be so careful to record all the relevant information and why everything that was done. So when a surgeon writes an op note, one of the things they're doing is they're documenting that they're following the standard of care. But it cannot be overlooked that they're also recording those details that are going to lead directly to the right CPT codes that lead directly to the correct billing. One thing you'll notice is that there's quite a range of awareness among clinicians about what billing codes are and what they do. It's actually unusual for their understanding to be all that deep about all the intricacies of coding. So that actually means that the folks who do the coding for the billing are actually more important than ever. They're the ones with the expertise on how to use those coding systems for accurate, complete billing and appropriate reimbursement. To a surgeon, it's often not intuitive at all how different details of their operation are going to influence the billing side of things. And I guess I can give you some specific examples. So your patient has gallstones, you're going to remove their gallbladder, cholecystectomy. So that has a CPT code related that you can bill with. Well, the code is different for an open cholecystectomy versus a laparoscopic one. That's a pretty obvious difference. A lot of other variations too, though. Did you explore the bile duct during the operation? Did you do an X-ray of the bile duct? Those are all different codes. So for the surgeon, they have to record everything they did, and experts have to take that document and they have to interpret it in the right way to really get the appropriate billing and coding afterwards.
Okay, so now it's starting to make more sense, and thank you for that detail, Julie. So is it true then that the better the documentation, the more impact there is on revenue? And Luann, you've had some good things to say. So what are some ways in which good documentation increases payments received or even reimbursement?
Well, a well-documented medical record can facilitate effective revenue cycle processes, expedite payment, reduce any problems associated with claims processing, and then help to ensure appropriate reimbursement. But that documentation, as we've said, It's got to include the medical necessity and then the appropriateness criteria for each surgery that was performed. And then also we've also mentioned that the appropriate codes for each procedure must be used.
Okay, so this all makes sense, but it is starting to feel a little bit like the overhead of all this documentation just has a cost to efficiency. So, but clearly the benefits of good documentation are very high. But and Janice, I'll go back to you. What are some guiding principles of documentation, specifically in the perioperative settings, that help overcome the challenges of cost-efficient care?
Oh, great question, Alex. I think to overcome the challenges of cost efficient care, we really need to measure the cost and outcomes using high quality data. As the others have alluded to, the quality of information available to clinicians affects the quality of care provided. And the quality of care provided can only be measured by the quality of the documentation. Luann mentioned the ANA's guiding principles for documentation. It states that nursing documentation should be accurate, timely, relevant, consistent, and more importantly, complete. The use of a structured vocabulary, such as the perioperative nursing data set, can describe nursing care and provides a way to measure outcomes for the perioperative population. Once we collect this information in a structured way, we can determine the cost-effective nursing care that improves patient outcomes.
That makes more sense. Thanks for that, Janice. And you talked about how a structured vocabulary can better describe the care that is provided, but it strikes me that it can also impact the accuracy of coding. So Whitney, we were talking about CPT codes a little earlier, and how important would you say it is to have the correct CPT codes documented within the operative notes?
Well, if everything is well documented, kind of piggybacking off of what Luann was saying earlier, billing following the procedure will be more accurate as the office or hospital staff that's reviewing those records. They'll be able to easily find and charge for the appropriate codes and supplies that were used. Since communication between coding staff and clinicians generally doesn't happen, the coders really rely solely on documentation and the operative note from the surgeon to do their jobs effectively and accurately. It's possible that CPT codes might be pre-populated in the op report, but the coder really makes the decision on which code is appropriate based on how that op report reads. If pre-approval is drastically different from the op report, then the codes can change. And as Julie mentioned earlier, the operative note may include additional things that were completed during the surgery and can affect which codes are appropriate. So kind of sticking with her example, converting from a laparoscopic to an open cholecystectomy triggers the need to use a different CPT code. And then again, if an intraop cholangiogram was also performed, an additional code would be needed as well.
Okay, so now this is a potentially big follow-up question. So in your opinion, what are some requirements that healthcare payers require to ensure that a service is consistent with the patient's insurance coverage and for validation purposes?
Yeah, that's a pretty loaded question, I would say. Insurance companies typically require the diagnosis, planned procedure. They may want validation of the diagnosis, usually a pathology or radiology report, imaging, labs, and the onus is usually on the surgeon and their staff to provide that information to the insurance company and not the patient. Specifically for Medicare and Medicaid patients, G codes have to get submitted with the CPT code. This usually triggers an advanced beneficiary notice to get signed along with consent. And most organizations know that if there isn't an assigned ABN, then the hospital or surgery center cannot bill or be reimbursed for that service that's provided. Coding staff also follows coding guidelines on when you can submit codes together and when you can't. There are also payer guidelines on what codes might be appropriate if a particular CPT code was pre-authorized. Oh my gosh, I can't say it, pre-authorized, but the resulting bill from the hospital can differ. Everything has to be aligned for timely reimbursement. Keyword there is timely. If things are not aligned, there can be delays on reimbursement and sometimes significant ones. And I believe on a no issue claim, reimbursement happens around 60 days, and it can take twice as long as that if there are discrepancies. Also, depending on the EHR, it may not be possible for multiple code sets to be pre-populated. An example that comes to mind is if it's an outpatient surgery, then only a CPT code would be needed. But if the patient ends up being admitted to the hospital, then both a CPT and a PCS code are needed. So codes need to be manually available to apply after the procedure when things change. So in general, the code used to schedule the procedure matches the billing code following the procedure. But as we've mentioned, the codes can change and organizations need to be able to pivot to get reimbursed appropriately.
Okay, so thanks a lot, Whitney, for taking on the challenge of that question with your thoughtful response. And given the time it is, I want to thank all of our panelists today for discussing some key areas of consideration about surgical documentation. So this was a great discussion, and I feel like we hit on some important topics, and I hope the audience today really enjoyed it. And with that, I'll close us out, and I hope that everybody has a fantastic week.